Good morning. My name is Kara Feldman-Hunt. I am the director of the Osher Center for Integrative Health. It's so lovely to see all these familiar faces. Welcome to Family Medicine Grand Rounds. For 15 years, the Laura Mann Integrative Healthcare Lecture Series has brought together leading voices in integrative health to educate and inspire our communities. Thanks to the Mann Family Foundation, this series remains free and open to the public and honors the legacy of Laura Mann. Laura was a skilled, beloved, and visionary nurse midwife who built the first integrative health center in our region. Each event is designed to deepen our understanding of how an equitable whole health approach can optimize the well-being of individuals, communities, and our planet. Today's talk will be recorded and will be available on the Osher Center website. You can also find some upcoming events on our website. We have one this afternoon on long COVID and acupuncture if you want to join us. So none of this would be possible without many of you in this room. So I'm going to just make a few acknowledgements. First of all, thank you so much to the Department of Family Medicine. We've been doing this lecture series, I see Tom Peterson in there, for 15 years with you all. So just thank you so much for hosting us and giving us a platform to make this happen and get in front of the medical community. Also, I want to just thank Dr. Patty Prelock, who is not here, as we know, and Dr. Steve Leffler, who's in the room. They really opened the doors for us way back when and really helped us shape the program that we have today. So thank you so much for making that happen. I also see Dr. Rob Altoff in here, and I just want to thank Dr. Altoff. That is where our clinical home is. The comprehensive pain program lives there. So thanks, Rob, for being such a creative and open leader. And also want to thank Dean Page and Dean Anderson for hosting our education and research programs. And that's where those places live. The Osher Center is a university-wide center, so we are everywhere. And now the reason we're all here. Today's lecture really carries particular significance. This lecture series was born from a collaboration with our speaker herself, Dr. Helene Langevin. We welcomed our very first speaker together, Dr. Peter Wayne, who's now the director of the Osher Center at Harvard and replaced Helene in that position when she went to the NIH. And that was back in 2011. So we go way back. I can remember that day vividly. And Dr. Langevin was the driving force behind integrative health here at the university. She started a program in 2005, and her work helped lay the foundation for everything we've built here. She went on to shape the national and global landscape of integrative and whole person health research at the highest levels. We're deeply honored to welcome Dr. Langevin back to UVM, this time now as the Osher Center's research director. We could not be happier. Dr. Langevin is the former director of the National Center for Complementary and Integrative Health at the NIH, a position she held from 2018 to 2025. At the NCCIH, she led landmark initiatives that elevated whole person health as a national research priority, including the Whole Person Reference Physiome, the Whole Person Health Index, and co-leadership of the NIH HEAL initiative. Between her time at UVM and the NIH, she directed the Osher Center for Integrative Medicine at Brigham and Women's Hospital and Harvard Medical School. Throughout her career, her research has centered on the role of connective tissue and mechanobiology in chronic musculoskeletal pain, inflammation, and cancer. We are so proud to welcome you home, Dr. Langevin, and we hope you will join us after the talk for a breakfast in the auditorium right out here. So thank you.
Oh, thank you so much, Kara. And it is, I cannot tell you how special it is for me to be here today. And how excited I am. As Kara said, I've sort of come full circle back to UVM, and I'm so excited. I think I'm coming back here at the exact right time. I feel like how the place where the Osher Center is and where Kara's leadership is taking us at the Osher Center, that's going to have an impact across UVM. And I'm just really, really glad to be able to come back to this. And what I want to talk about today is really sort of a vision that I'm sure share with many of you, that, University of Vermont is already a leader in this field, in the field of integrative health, and is poised to really move the conversation in ways that are truly remarkable. So I'm just really glad that I'll be hopefully be part of this. And so what I want to talk about here is a vision of whole person care as good medicine for all. But I'm actually going to start with a problem. And we all know that the health of the U.S. Population and the U.S. healthcare is in trouble right now. This is a graph that came out in 2014 that actually shocked healthcare economists in this country. And I remember I had just started my work at the Osher Center at Harvard Medical School at the time. And this has really revealed that the United States is kind of on a trajectory of its own when you plot healthcare expenditure per capita to life expectancy, where we're spending a lot more on healthcare, but our life expectancy in the US is actually worse than all the other comparable developed countries. And even more shocking is what has happened since then. You can see here that from 2014 to this graph ends in 2023, the healthcare expenditure has just continued to spiral out of control. It's now double what most the other comparable country averages. Average. And so if you look at the dip in what happened during COVID in the United States compared to what happened to other countries, it really tells you that even though we're putting a lot more money into healthcare, we're really not improving the overall health and what's going on. We know that a lot of this excess mortality was due to overdoses and increased suicide during COVID, but that's not the whole story. We also know that a lot of this excess mortality is due to chronic diseases. These are diseases that are a lot of them are preventable, but we're not really doing a good job. And so largely driven by the sort of rising obesity, diabetes, type 2 diabetes, cardiovascular disease, et cetera. You're all very aware of this, I'm sure. So what is less talked about, and what I really want to start by, kind of laying down the foundation for the problem that whole person health is aiming to try to solve, is that a lot of times these diseases that we talk about are what we call co-occurring, meaning they occur in the same person. And so the same person will have cardiovascular disease, diabetes, they'll have degenerative joint diseases, they may have depression. There's a lot of these problems that tend to sort of, happen in the same individual. But what happens is that our healthcare system still, because of the way the healthcare system here is built, we tend to address these problems one at a time. And so we treat all of these different diseases, typically with drugs that address the pathophysiology of the disease as we understand it, which is appropriate, and it can be extremely, successful and life-saving once the disease is established. There's really a lot of times no other way to treat it. But what we are not so good at, and we know that a lot of these diseases have preceding factors that lead to them. And interestingly enough, these factors, poor diet, sedentary lifestyle, chronic stress, and poor sleep, these things are risk factors for many of these chronic diseases. And so, but we know that it's hard, right, to address these factors. We know that, for example, lifestyle interventions, diet, exercise, et cetera, are first of all difficult for patients to implement. Very often when people will implement them and be successful, it doesn't last. sustained behavior change is hard. We all know this. This is really a difficult problem. I put here chronic stress and poor sleep first, because I want to stress that a lot of times that is sometimes the straw that breaks the camel's back for a lot of people. It's very difficult if you want to try to stick to a diet or to exercise if you're exhausted because you haven't had a good night's sleep. And so a lot of times the stress is not getting any better. The levels of stress, especially in the U.S., when you compare stress levels globally in this country, are very, very high, and they're getting there. And it's self-reported. Stress is a huge problem, worldwide, but especially here. And so this is an issue, and one of the reasons why I think we need to start, addressing this problem of fragmentation of care is because it's really sort of built in the DNA of medicine, right? This is how we have over the last, century plus, we've sort of gotten really, really good at what I call analysis, which is breaking down, body into different systems, understanding molecular signaling pathways, for example, cellular processes, and then down to the gene level. And so we are really good at developing treatments that address these sort of complex, sort of, very, very detailed and analytic knowledge that we have of the human body. We also know that synthesis is important, integration. Understanding, for example, how the different organs and systems of the body relate to one another. Endocrinology is a good example of that, right? That's been known for a long time. There are other systems of the body that are connectors of different organs, but more or less in large. I mean, at large in medical school, for example, we tend to learn the systems separately, and there, medical specialties are organized this way. Medical education, academic departments, even NIH, right, is organized around these organs and systems. And so it takes effort to point the arrow back in the other direction, but it's not impossible. Systems biology is a great example of that. We're starting to understand how molecular networks, for example, reach across a variety of different systems that we used to think about, on their own. So I think that increasingly, right, we're really starting to see humans as a part of a complex ecosystem. Here I'm at the University of Vermont, where we really understand the relationship, and there's a lot of emphasis on understanding how people relate to their external environment. But this environment is complex, and it also is within the person, and then how the person relates to their sort of social and physical environment. That's all connected. We know this. So what's the solution? Well, why don't we try to see whether we can address all of these various different factors that lead to these chronic diseases together in the same person, in the whole person, right? So what would that take? Well, it would take what we call multi-component interventions that address psychological, nutritional, physical aspects of health, and also that emphasize self-care and support, right, for the behavior change, both individual and social level support. Well, that's a tall order, right? And so when I came to NIH back in 2018, I started having conversations, across NIH about, what would it take, to do research on whole person health. And I got a lot of honest skepticism, well-founded skepticism about, how would you do this? I would get comments like, my goodness, you're trying to boil the ocean. I mean, how are you going to do this? I mean, it's been ingrained into us about good, research study designs and statistical, hygiene. You're supposed to have, focus on a primary outcome, looking at multiple outcomes. I mean, that's like a recipe for disaster, and this whole thing about multiple comparisons and, messy research designs. I mean, that's just not supposed to be how you do science. And so it was kind of daunting, how are you going to approach this? So we decided to take the bull by the horn. And in 2021, we put together a trans-NIH working group on whole person research. And this was with multiple institutions and centers throughout NIH. And we held a workshop on methodological approaches to whole person health. And this was a real game changer, this workshop. And we really had at the table many other institutes that were really grappling with this problem. And one of the main partners that we had in designing and holding the workshop was the National Institute on Aging, because aging research kind of already, that has been also their thinking, is that your organs and systems don't age, one on their own. It's the whole person. And they're already starting, there was efforts to try to develop signatures, right, of overall phenotypic signatures of healthy aging as opposed to less healthy, and how to calculate, for example, indicators of like the pace of aging. These kinds of research were already well underway back then. And so it was clear that the methodology for looking at a complex whole person clinical problems, such as, for example, co-occurring multiple diseases, was not impossible. In fact, the climate sort of in understanding how to handle big data it's amazing. This is not that long ago, right? 7 years ago, but it was just at its kind of inflection point. People were starting to realize that the technology was there, the know-how was there, and the beginning of artificial intelligence was just starting at the time, and understanding what the capabilities, what those capabilities would give us. So tackling the problem of whole person health at that time was kind of a good timing. So at this workshop, we broke it down. We thought, okay, we're not going to start all doing the whole person all at once, right? So we had various things. So we looked at how do various different systems of the body connect together? And then how do you study this is at the upper left. And then on the upper right, how do you study the impact of a single intervention on multiple systems? Okay. And then how do you look at the effect of multiple interventions, lower left, on one outcome, on one organ, let's say the brain. And then finally at the bottom right, the whole thing, right? You don't start with the whole thing, and so that's kind of what the workshop, it took out a little bit some of the anxiety that people were having about, can't just do research on whole person health, that's it. You can't just get to the bottom right all of a sudden. You have to just do it in pieces. The other thing that perhaps even more important that was happening at the time was that the realization that there are different processes in the body, that there are processes about what we call pathogenesis, which is how disease happens. And then the reverse of that would be salutogenesis, right? And this is actually not a new term. It's a term that's been around since, I believe, the 1940s. But instead of the generation of disease, it's generation of health. What we don't know is salutogenesis just pathogenesis in reverse, right? Or are there other pathways? Imagine that you were able to visualize as this stick figure, the entire metabolic pathway of a person as they move from a healthier state to a less healthy state, or vice versa, from the less healthy back to the healthier. How would that metabolic pathway shift? And would it shift the same way in one direction versus the other? Very important question. No idea. We have no idea of the answer because we haven't studied it. So right around that time, there was a project, a program, Common Fund, NIH Common Fund program on artificial intelligence called the Bridge to AI. And that was started back in, I believe, 2020. And the goal of that project was to generate what we call AI-ready data sets, because people realized at the time that you can't just take a whole bunch of messy data and throw artificial intelligence at it and get anything but garbage out, right? You have to collect the data in a way that's intentional, that is properly annotated, that's ethically sourced, properly de-identified. There's a lot of things that go into this, right? And so we put in, and I was one of the co-chairs on that program, and we put in a request for applications, and lo and behold, one of the applications was on salutogenesis. And it did very well. We ended up funding it as one of 4 applications, 4 programs. And this was led by Aaron and Cecilia Lee at the University of Washington University. And what they proposed to do is take a cohort of patients with early type 2 diabetes, and then do phenotype the wazoo out of them, just measure everything, and then do what they call a pseudotime manifold analysis, which is a way to do clustering based on, reducing the dimensions, and see how these various clusters of individuals separate, whether or not they separate, and people who are managed with just diet and physical activity, those that are on medications, and to see whether improvement in health is different when people are managed with the lifestyle interventions versus the medication, and who improves and who doesn't improve. And it was this project is still underway, and obviously this analysis is going to have to be validated, right, with actual real-time data that will kind of, because this is a cross-sectional data with what this analysis does, and then eventually this will have to be validated with data over time. But this was a very interesting kind of approach that was very new. They had borrowed this technique from single-cell RNA-seq analyses, where they do this type of analysis to project and predict molecular pathways and so this is the first time that this had actually been applied to humans. So it'd be very interesting to see how this program and the goal of the Bridge to AI is to make all these data sets open and accessible. So it's going to be very interesting to see how people use these data. It's already going to be it's already a lot of really cool publications from it. So the other thing that became clear is that as more and more data are being generated, it's very clear that to use AI and to build these sort of explanatory models of disease or health or whatever you want to do, you need a foundation of knowledge that you can report back to, right? This is extremely important, because you need to know what we call the ground truth. And what is the ground truth? Is what we know is true, right? There are some things that in medicine we have known that are true for a century, How do you have this kind of essentially a knowledge base, and specifically for the whole person? Well, what would that be? Well, essentially probably like a textbook, right? So if you want to understand human health, and you want to understand the health of the whole human, you would go to a textbook of physiology, right? But we don't have the equivalent of a textbook of physiology, of healthy physiology, in network form. That just doesn't exist. But that's what we need, right? In order to be able to take the data, all this data that we're getting through programs like Bridge to AI and all kinds of other projects, and essentially create new knowledge based on these new data. Extremely important problem. And so we got together again with our whole person Trans-NIH whole person working group that had now grown to 20 NIH institutes and centers. That's 20 out of 27. That's pretty much unheard of at NIH. And we we put an RFA again, and we funded this fantastic program on a whole person reference physiome research and coordinator center. The group that's doing this is led by Michael Snyder at Stanford, and with also collaborators at Penn and Indiana University and Harvard Medical School. And this is the importance of this physiome. I cannot stress enough, and I'll tell you a little bit about it. What they're going to do is they're going to create a whole person network of physiological function that goes across all the organs and systems, right, based on existing knowledge. And this is what's in blue here. And what they're going to do is they're going to graft this on to the existing cell hub map. It's called a Human Reference Atlas. And this is led by Dr. Kadi Borner at Indiana University. She's the principal investigator of this. That's another NIH Common Fund program. And what the hub map does is it creates a map, essentially, of the whole body anatomy. So I'll show you what that looks like. So this is the Human Reference Atlas. Just as we're 3 organs, we're just a pancreas, liver, and kidney, okay? And you can drill down, through you have every single structure, gross, for example, the kidney, you would have, the glomerulus and the nephron, the loops of Henle and all these little structures. And inside of these structures, you have all the cells and the functions of these cells, as we now know what they do. They're all their genotypic signatures. It's all grafting onto the Human Cell Reference Atlas that is from the single cell RNA-seq studies. So this is incredible because it links gross anatomy to essentially cell and molecular biology for all the different organs. And the nice thing about this Human Reference Atlas, it also goes across all these organs. So going back to this, you can see that they're going to take the physiological layer, the function, what do these organs do? What does the heart do? What does the kidney do, et cetera, and graft it onto this existing network structure. Very, very powerful. So then what they're going to do is they're going to see on the left is the anatomical structures, and then on the right is the physiological functions. They're going to start with the simple functions, the heart pumps the blood, that kind of thing. All the stuff we know. This is not built very importantly, this is not built using AI. Okay, this is built using people's brains. And they're going to have experts from all of these disciplines that are going to come out and form committees and hash it out. And really, and they know how to do this. I mean, to make sure that everybody agrees on all the principal functions of all of these organ systems and how they relate to one another. And then once they do that, then they'll move on to more complex functions like circadian rhythms and sleep, et cetera. So back here at UVM, we have this really, really amazing project that is called the Lived Experience Measures Using Ring Study, or LEMUR. That's a Complex Systems Institute that is, in my opinion, very much kind of in concordance with a lot of this thinking on whole person health. And I can't wait to learn more about this. And it's, I think that the potential is because, here at the University of Vermont, we know how to think ecologically. I mean, I think it's really part of how this institution is we understand, for example, the relationship of humans to the environment. That's really been part of the focus of the university for a long time. And so, and I think a project like this has so much potential in that. And I really can't wait to see what happens next with this. So this is essentially a project where not medical school students, UVM, 600 students, I believe, are given these rings, Oura rings, and map their physiological function over the 4 years of their schooling. And meanwhile, they're having questionnaires and about how they're feeling, their mood, their stresses, et cetera. So it's going to be, and so they're already finding out interesting relationships between autonomic control, sleep, and physical activity and perceived stress. Very, very important study. So I'm really excited to see more about that. So shifting over to the patient care aspect of things. One of the questions, of course, that we, were asked right from the beginning is, how are you going to know if whole person care works? It's how are you going to measure that? It's one thing to do fancy physiological studies, spending millions of dollars and phenotyping people and making all these measurements, but you're not going to do that in the clinic, right? So it's almost the opposite problem that you have in the clinic. So far we understand whole person health as a very complex physiological problem that we need to understand, right? And for that you need brute force, more than brute force. I mean, you need essentially a very complex and costly, essentially, research enterprise. For the clinical assessment, it's almost at the other end of the spectrum. You need something that's very simple. You need something that you're going to be able to apply to everyday patient care that is going to help you to understand whether a person is moving towards health or away from health. It's a very different question than asking if a treatment works. When we give somebody a drug, we want to know, does the drug work, right? What is the therapeutic efficacy of this drug, and compare it, to a placebo, et cetera. But in whole person health or in lifestyle interventions, it's not the treatment that's working, it's the patient, right, that's doing the work. All what the treatment is doing is facilitating, supporting, helping, and so assisting, I like to think about it that way, the patient in helping them to move towards health. So I think that it's important to really think about that in terms of the kinds of research questions that we can and should ask. So we thought, well, how are we going to facilitate this kind of research, right, on whole person health and whole person care? We wanted to develop a concise instrument, and I underlined the word concise because that's really important, right? If you want to assess whole person health and you're going to develop an instrument that has 100 questions in it, nobody's going to use it, right? And to measure the direction of health and what I call the health trajectory, is the person's arrow going this way or that way? For the whole person, and importantly, from the patient's point of view. This is not something that this is not the only thing that's important. Of course, objective measurements of health are going to be important. Understanding, developing health signatures, these kinds of things, understanding how to use biomarkers. This is to understand health. This is all stuff that we need to understand and do. But for patient care, we really need something that is patient-centered. We looked at the existing instruments, and this is the Promise 29. This is an instrument that is used extensively. It's an instrument that was developed actually through NIH funding. It was also a Common Fund project some years ago. And we looked at some of the questions, and what struck us when we first looked at that, and I'm going to, if you just read some of the questions, I'm fearful, I find it hard to focus, I worry, I feel uneasy, I feel worthless, helpless, depressed, hopeless, fatigued. The list goes on, I have trouble doing my regular activities, I have trouble doing it. It's negative, it really focuses on symptoms and on uncovering what is essentially wrong, with the patient. And this is something that we wanted to really do the opposite of, not the opposite, but the flip side of that, which is to understand what are the indications of positive health. And because there's a lot of things that people are already doing that are helping them to be healthier, but we're not asking those things in these types of questionnaires. So we happen to be having discussions with the CDC. They were frustrated because at the National Health Interview Survey, this is the largest survey, pre-existing survey of health in the country. It's been going on for decades. And they do surveys of 40,000 households. These are in-person interviews. It's really the gold standard of health. And we were having conversations with Stephen Bloomberg, who's the director of the National Health Center for Health Statistics. And they had the same frustration. They said that they're in the National Interview Survey, Health Interview Survey, it's not about health, it's about diseases. So they wanted to develop an instrument like that too. So we partnered with them and we developed a set of 9 questions So basically the questions are, and we wanted to be, our benchmark, we wanted less than 10. We ended up with 9. How would your general health, quality of life, rating your social and family connections, your diet, your physical activity, stress management. We thought that was really, really important. That's missing from most questionnaires. Sleep, sense of meaning and purpose, all the feedback. We did a RFI, a request for information at NIH before we did this questionnaire. Spirituality and meaning and purpose, that was one of the things that people cared the most about. We felt it was really important to have it in there. And then health management, ability to manage your health, focusing on aspects of your health that matter the most to you. And we learned that actually from the VA. The VA had a wonderful program that's already been on for decades or more on whole health. And this is, their motto is, what matters to you? It's not what's the matter with you, it's what matters to you, which is a really interesting, I think, sort of way to think about it. So you can see that taken individually, these questions are not, I mean, you're not going to know everything about somebody's diet by simply asking somebody, how's your diet? That's obvious, right? The point of this questionnaire is not to have the most accurate answer on every single domain. It's to have the gestalt of the whole thing. And there's actually a paper published that's currently in press for the CDC, by the CDC on the psychometric analysis of this questionnaire, where they did very extensive evaluation of the questions one at a time, and they compared them to a more detailed questionnaire, like for sleep, for example. They compared the one question to an established questionnaire with 10 or 15 questions on sleep. Correlations were moderate. They were good. I mean, they were good enough for a questionnaire like this. And when they looked at the totality of the answers, they felt that there was represented a single underlying construct, and that's really important. It really shows you that this questionnaire is more than the sum of its parts. And they did focus group analyses on people, and what they found is that people got that as soon as they answered 2 or 3 of these questions. They kind of got the idea, oh yeah, they're asking about the whole person. So the other thing that you can do when you have 9 questions like this is you can aggregate it. Each question is scored on a score of 1 to 5. And you can aggregate by simply adding up the scores. And you can see that it would give you a score, the bigger score in indicating better health, and then a smaller score, less good health. And so remember, I was talking about not using multiple measures, right, in clinical trials. So you could use one measure, which would be the whole person health index, once we understand how it changes in response to an intervention, to hopefully eventually power a study on the whole person health. Now that's going to take some time. But in the meantime, we were talking to the All of Us study. I mean, if you're familiar with this is a study of over, their goal is to have 1 million participants. They're up to like 800,000 or so. And we wanted to find out whether they might be interested in deploying the whole person health index in All of Us, because All of Us is a database that includes it includes electronic health records, and includes genomic data, it includes environmental exposures, it includes wearable data. They were really, really interested. They wanted to do it right away. They put it in last year, and they had a pilot study. And within the first week of putting it, they had 48,000 people fill it. I mean, that indicated that this was something, and that this is just something they put out there for people to voluntarily do, and they just did. So many people did. It really, what we're finding in conversations everywhere is it really filling a void. Just to give you an example, this is a very typical study results of a study that we see of mindfulness-based intervention for chronic pain. And you can see here that there's 3 groups, usual care, and 2 different mindfulness groups, and their effects compared to usual care they're statistically significant. But look at the y-axis, it doesn't go to 0. What does that mean? It means that these effects are tiny. They're very small effect sizes. They're barely clinically significant, and that's a real problem. But they also measured other things. Interestingly, they had a lot of secondary outcomes. They had perceived change in pain, but also physical function, fatigue, sleep, social roles, etc. And all those were statistically significant, but small. So the idea is, what if you just added up all those small effects and you integrated them? Would you get something, a larger effect size? We don't know, but we think that this is worth trying. And this is where I'm really excited here, because at the UVM Comprehensive Pain Program, we already have a program that has been really shown to be very, very impactful from a patient care point of view. And also, this is a group with weekly sessions that include a variety of different modalities, and it really addresses the whole person. And the important thing is that there's already been showing that this group treatment management of chronic pain is economically viable. That there were large reductions in emergency room visits for patients with chronic pain who did this program. And this was replicated. The first thing was in partnership with Blue Cross and Blue Shield, but it was also with a subset, a pilot study on Medicaid participants who are very difficult treatment group patients to treat. And you can see that there are robust changes that you see that measure the clinical effectiveness of the cost effectiveness of this study. So we also did an imaginary study of an individual who is treated in two different ways: conventional care using medication and surgery, etc., and then the whole person care, which is this is the version B at the bottom, which includes sort of non-pharmacological interventions, lifestyle interventions, support, in addition to medication, not entirely, but and compared the management of these two cases. And then we partnered with the RAND Corporation to do a cost analysis of this imaginary case. This is just based on a case history, and calculated the healthcare spending over this individual's lifetime from age 40 to age 80. And you can see that there's a big difference between the amount of money that's spent on the long haul on a patient when they have early support. In the first 4 or 5 years of this study, the whole person care, if anything, is more expensive. But then eventually there's substantial cost savings compared with the conventional care. This is something that actually CMS is paying a lot of attention to, because it's very difficult, obviously, to do a study like this with such a long time horizon. You'd have to follow somebody for 40 years in order to demonstrate this in a cohort of individuals. But there are ways to do statistical modeling, and in any case, this is just an example of how you can start to think about this. So again, we think that the Whole Person Health Index might be very useful to apply to a comparison, right, of conventional care versus whole person care, and also of physiological analyses, right? Because when you're looking at a mass of data from different studies, like I showed about before with the Bridge to AI study on diabetes, et cetera, it might be very useful to have the Whole Person Health Index to use in combination with complex physiological measurements. So we think that this Whole Person Index might be very useful in a variety of different settings. First, in the physiological health measurements as a benchmark to see whether to sort of compare physiological signatures, for example, with a whole person assessment, and also for evaluating cost effectiveness, and value of a treatment in the clinical side. So we're really wanted to deploy this, and we're starting here at UVM, and this is where I think UVM is a very, very interesting laboratory for a concept like this. We're going to start with the Comprehensive Pain Program, the Levy Whole Health Cancer Program, and implementing the Whole Person Health Index try to put it into EPIC so that it's easy to use. And our goal would be to really hopefully deploy this across as many patient care centers or groups of practice groups are interested in doing it. And we're thinking even across UVM Health. It would be very, I think, useful to have this in rural areas, to look at the health of the rural population as well as urban. And then eventually we have other partners, or the Osher Centers. The Society for Integrative Oncology is really interested right now. We're going to be deploying this and across integrative oncology clinics across the country, as well as the Academic Consortium for Integrative Medicine and Health members. So you can see that we're not basically this whole person health index is essentially a first, what we call the beta version. It's the first pass at this. We're going to see what kind of data we get. We're going to see whether it's sensitive to change. We're encouraging people to include this as a secondary outcome in clinical trials, not obviously a primary outcome because we don't know yet how it changes. But then based on these data, we can either modify the questions if needed or use them eventually once we have the data to power clinical studies. So it's a change. It's a really a work in progress, and we think that it could be transformative because it really encourages people to think holistically. And this is not something that is easy. So having an instrument like that is simple and to be used in combination with more complex sort of physiological measurements, we think can address the problems from both ends. So I hope that you share my enthusiasm for whole person care and whole person health. And I think that I find it very interesting how our brave little state, could be a model for the nation. A lot of people are watching what's going on at our comprehensive pain center. It's really generating a lot of attention nationwide. Other places are copying it. And I think we can take it to the next level with whole person health and really put this as a model that other centers, starting with our partners, but moving forward. And I can say that at NIH, there is a lot of interest in this across NIH. And the change, the rapidity of the change and the adoption of this concept across NIH was really remarkable. From just the time that I was there 7 years, it has really become almost a motto that you hear everywhere. And so I think you're going to find that those of you who do research and who are applying for grant funding from institutes, it's not just NCCIH that's interested in this, it's across NIH. So we think this is very good news. So thank you for your attention, and I look forward to any questions.
Thank you so much. That was great. I just wanted to get the mic out so that anyone who does have a question, I'm going to bring it to you so that everyone online, which you just crushed the record for attendance this year. Oh my God, there's 82 right now online. And I didn't look at the very beginning to see if any dropouts occurred, and look at the in-person attendance. So thank you, Kara, for that. It's been really fun. So questions, anyone? All right, thank you.
Thank you. Thank you so much. Excellent presentation. We really appreciate it. I'm curious if there's a way to cross-reference or understand the economic implications. The chronic stress, sleep, diet, et cetera, are so affected by financial challenges. And I'm just curious if it doesn't appear as a question or related to in one of the 9 questions. Just sort of how to track the data over time.
That's a great question. Thank you so much, Gita. Yeah, so we're talking about the bigger things of what we call the social determinants of health, right? So when we started developing the Whole Person Health Index, we were doing this in collaboration with other institutes at NIH, and notably the National Institute of Minority Health and Health Disparities, National Institute of Nursing Research. These were the two, and these were the two partners where they had their own working group to develop common data elements for social determinants of health. And I was part of this working group, and they were kind of debating as to what should be the types of, and they were trying to develop again one of those sort of instruments to measure all those different dimensions, sort of social, physical environment, economic, and financial, et cetera, well-being. They decided that they wanted to only include factors that are external to the person and did not want to include individual behaviors like diet, like exercise, that kind of thing. And we thought, that's very interesting. Okay, well, we'll take that then. So we developed this questionnaire focused on individual level factors that were more under the person's agency and control. Not that your finances are not under your control, but that somebody's basically just kind of socioeconomic sort of, background, surroundings, et cetera. A lot of this is external to the person. So that ended up being in a separate thing. So what we envisaged, this whole person questionnaire could be used in conjunction with established questionnaires on social determinants of health. That's how it happened. So not that it couldn't be combined, it could be. And so the whole person health index doesn't tend to cover everything, right? It's just, I think it filled a void, a need, that a real gap that wasn't there. So that's how the story happened. Yeah, hope it answers your question. Yes, John.
Can you hear me okay? So this is an easy one for you, but it's really just asking for a comment, because part of what I see in whole person care, as opposed to traditional care where we're treating an organ, treating a system, is the possibility of social transformation, right? Because when you look at how people are treated individually in a holistic way, and you look at populations that way, it runs potentially pretty quickly into some of the challenges we have socially in terms of marginalized population, in terms of economic disparity. So I wonder on that global scale, what you see in terms of this movement affecting that larger social system, first of all. And then the second part is, how do you see a relation over the longer term between human health, planetary health, and that reciprocal relationship? So I wonder if you could just...
Yeah, you're talking about the ecosystem, right? And when we first starting to come up with a definition of whole person health, and I'm not wild about definitions, but our first definition, the way our starting point, and this is how we built our strategic plan, actually, back in, at NCCIH, I still say we, at NCCIH back in 2021, was empowering individuals, families, communities, and populations to improve their health in multiple interconnected domains. That's kind of how we started, understanding that what the individual is connected, obviously, to their families, to their communities. You can't separate it. And then to the planet. I mean, what's good for, we know increasingly that what's human health and planetary health are linked. There is no doubt about that. It's just that it's such a they're both such daunting problems that it seems easier sometimes to put them in separate buckets. But no, we know that there's a connection. I think that if we think about a family, for example, as an ecosystem, obviously what one person eats or cooks affects the other members of the family. There's no question, right? And so I think that we can think about whole person health as going in both directions. Each individual as action radiates around their surroundings, their community, their family, and then vice versa. We're all affected in this. So it's all about really thinking that, going back to that diagram. I love that diagram that our artists at NIH made for us about that. The thing about a complex system, we know, is that every individual affects the whole, and then the whole affects every individual. And so, yeah, it's a different way to think, but it's a good one, I think. So thank you for the question.
Anyone else out here? Oh, I see a hand.
Yeah.
I turned it on for you.
Oh, thank you. Thank you for this. This is fantastic. The whole person health index is adults only at this point?
Yes, so it was developed by the National Health Interview Survey, which is a survey of adults.
Yeah.
So it has not been yet validated or even attempted to use in children. It would need to be, tested and validated for kids, for sure. They would not be the same questions.
Right.
But
That's actually what interests me, because you started talking about the family. We have,
Yeah.
Basically in child psychiatry here, we do an awful lot of work with families.
Yeah,
Right. And the whole, exactly what you said, what one person eats, especially if it's one of the parents,
yeah,
what they eat, affects what the entire family eats. And sometimes what they choose not to eat affects what the kids will eat as well. And if there were an instrument that we could then expand when we're looking at things like going across the health network, that we could expand and look at this from a family standpoint,
yeah,
it really amplifies the effect. When
Yeah.
you look at your graph that's
Right.
longitudinal, right, you change the trajectory at the beginning of that long line. It affects the trajectory all the way along the long line.
yeah. Great comment. And I this is just a starting point, right? This is version 1.0. And we see this as, I think of this as a bit of a disrupting technology or disrupting, it's really pushing change. And questions like the one you have, what about kids? And then, the first thing we had to do is we had to translate it. We translated it got translated into Spanish, and how would the questions be? It can really, the other interesting thing is the other end of the spectrum is aging. Like one of the things that the National Health Interview Survey did is they looked at whether the responses to questions changed as a person across the aging health span age. And they didn't look at kids, though. This was only for adults. And what they found, there was only one question where there was a correlation with age. And that was the very first question. How would you evaluate your health? All the other questions were pretty much age agnostic, which was very, very interesting. And that first question, in fact, is a bit of an oddball, because that very first question is, we decided to use it because it was already in the National Health Interview Survey. It was sort of a freebie. And they wanted it because it kind of helped them anchor it to what they already have. But that question seems to behave differently than the other ones for some weird reason. And they're looking at that. We're going to try to look at analyzing responses with and without question one, because it might be actually very interesting. So, but going back to kids, I think, yes, we would definitely, people are going to have to just do that. Developing and validating these questions is not cheap. I'm not sure whether the CDC would want to do that or not. But people are certainly welcome to do it and put in a grant application to do it. I think the NIH would probably be interested in funding that. Yeah.
Dr. Langevin, I have a question from our Zoom audience, and it's from Jeremiah Eckhouse. And he asks, how might the WPHI be used to measure large populations, and how does it fit with questionnaires that focus on eudaimonia or well-being? Would they be used in conjunction?
Yeah, well-being is a very interesting one. So as I was talking about how that initial conversation that I had with the director of the National Health Interview Survey, we were actually at a state-of-the-art conference on well-being that was held by the VA. And we were all discussing, going around and around the mulberry bush about well-being. And it was so hard to define well-being. It is a very, very difficult, the way we sort of decided to deal with that is to really think about the aspects of subjective health that overlap with well-being. So, some of the questions in the Whole Person Health Index reflect that, but we don't use the word well-being itself. So I think that the two concepts are certainly very much, related, quality of life and feeling of meaning and purpose. A lot of these is very much related to well-being. So, I think that, and then the beginning of the question was about population health. I think we'll have to see how useful is this questionnaire for comparing groups of people, I'm a little weary about that. I think it's probably more useful within an individual to look at changes over time. And again, we're going to have to see, how sensitive is this to change? But that's certainly one of the things the CDC wants to do, is to try to see, to look at their entire population and to see how does the whole person health index, they're going to compare, different socioeconomic groups, different ethnic groups. I mean, there's going to be a lot of very interesting data will come out of this. Yeah.
Thank you. There's one more question in this chat for the meeting today. And this one is first a comment noticing that Osher Center is starting our day with a wonderful presentation and ending the day with the acupuncturist Brendan Kelly. And seems to this person that the whole health framework aligns with the healing philosophies of many ancient wisdom traditions, such as Chinese medicine, Ayurveda, Yorubic medicine, to name a few. The question is, how do you see Western medical research interfacing with the wisdom of these traditions?
Oh, I love this question because this, in fact, one of the motivators I didn't tell you the whole story, but back when I was at Harvard Medical School, one of the ways that I became interested in whole person health was because, at the time, integrative health, the meaning of integrative health was about taking complementary therapies like yoga, acupuncture, those kinds, and putting them together with conventional care. That's what was integrative health is, and it still is. But I really thought, geez, it's more than that. It's really integration across the whole person, because that's what these therapies do. If you ask people what they appreciate or what they enjoy going and having an acupuncture treatment, it is because it's about their whole person. So it was almost like a hypothesis in my mind, is that what about the concept of whole person health? How well would that be reflecting the philosophy or the intent of integrative health, practitioners? So we got together but by the time I got to NCCIH, we put this out as to say, let's see whether we could, because NCCIH did not have a coalition, a group of stakeholders that support it, didn't have that, because they were all separate kind of professions, acupuncturists, chiropractors, they all had their separate interests. So we said, okay, what about whole person health? There was this incredible outpouring. We had our first meeting of the coalition. We had over 100 organizations that came and that wanted to be part of this. And all of the different acupuncturists and different professions, integrative and complementary therapies, they saw themselves in there. It was a way to get people together around a common theme. So yes, I mean, and then the kind of research that would be needed to understand how, for example, traditional Chinese medicine follows or, fits into a whole person health model. Absolutely. And this kind of research is not easy to do, but it boils down to having the right methods, having the right methods to study these complex interventions that doesn't dilute them down and that preserves their philosophical integrity, but yet is methodologically rigorous. So this is something that definitely I can say for sure that NCCIH is going to continue to be very interested in funding. Yeah, very important.
Well, thank you very much. It's a couple minutes after 9, so I think we maybe ought to move on to the reception. Kara?
If the caterers would arrive, which they have not.
Oh, shoot.
So Kate would text me, very sorry, but the caterers are lost somewhere. So we don't have food as of a minute ago, but maybe it's out there, who knows? So if you want to hang out and ask Helene any questions afterwards, please do so and just mingle. And very sorry about the lack of coffee and food.
Well, maybe they'll show up. Thank you. Thank you.